Welcome to our podcast, PA Mindset Matters. I'm Mercedes Dodge, and we're excited to introduce you to our mini mindset editions. With Jessica Spissinger and I, we've created these short episodes for PAs, PA students, and all healthcare providers who want a moment to pause, reset, and reconnect with purpose. In each episode, we will explore reflections, practical insights, and a mindset shift you can apply right away in your training and in practice and in life. Because how we think shapes how we show up for our patients, our colleagues, and ourselves. So let's get started. So welcome back to the Mini Mindset series. Today, we're going to actually do a deep dive into something that impacts every single one of us in clinical care, and it's called collaborative care. So we're going to talk about how mental health shows up everywhere. So it shows up in fatigue, in primary care, chest pain, in cardiology. We have a lot of behavioral health concerns in the pediatric clinics, but even though it shows up there, care is often delivered in silos. So that disconnect is what happens when people aren't talking or communicating. So they fall in the cracks. When care is siloed, patients move between providers without a shared plan. So what we see is really not pretty. Misdiagnoses, fragmented treatment, polypharmacy. And honestly, we see a lot of provider burnout. So this is really not a knowledge problem for providers. It's really a system problem. So I really want to emphasize that when I talk about collaborative care, it's not a problem with providers. It's more of the system, but we need to make some changes in order to deliver more comprehensively, holistically, and also just collaboratively.
Are you going to break down this statistic? Because
Yeah, I'm
276
gonna go to.
is wild.
It is wild. I'm so glad that you're asking this. I'm going to break them down. I'm not going to go through them without explaining them because I like these statistics in regards to how impactful collaborative care can make positive change. So the first statistic is 50% of patients are not adequately treated or engaged in care. So this is if they come in for care with there is diabetes, for example. Diabetes doesn't appear in silo, right? So when we have the diagnosis of diabetes, there is high risk of depression. And so a lot of patients are given silo care without whole body care. So 25% drop out of treatment too early. So what we're talking about is patients go to a primary care setting and they start an SSRI. They start an SSRI and they're not likely to continue staying on it. They drop out early compared to a lot of the collaborative care research. Basically, what the study shows is that patients who get behavioral health treatment integrated in primary care settings, they have less dropout treatment. So they are able to continue the medication longer as well as get into remission. So that's an interesting stat. So the last stat is, so for commercially insured patients, when a behavioral health diagnosis is present, the cost to provide care jumps from $340 per member per month to $941. So that's where the plus 276 increase comes from. So basically, again, when a behavioral health diagnosis is present, the cost jumps for care for that member per month. If we want to reduce cost, we need to integrate behavioral health care, all types of clinics. Basically, it says mental health care itself can be expensive if it's not comprehensively managed, right? So mental health shows up everywhere is my big thing. If you don't address it collaborative way, you're going to see more ER visits, more specialty referrals, more imaging, more hospitalizations. And so we're seeing this higher cost because of the inefficient care in the system. I like these stats because it's emphasizing collaborative care can flip this all.
Mm-hmm. Okay.
So redefining integration. So I like to break it down to just these three categories. So collaborative care is shifting from just giving them a referral and saying, go see the therapist or the psych provider, to co-management. Consultative referrals is what we typically see a lot of us just doing, refer to psychiatrists or psychiatry. Co-location is you have a psychiatry in the department associated with your office or company. And then collaborative care is a little bit more structured. And it's not something that you can just, I'm going to do collaborative care next day. You have to set up the stage, which is the right people. So you need a psychiatric consultant, could be a psych PA, MD, You need to have a case manager, which can be a trained MA, it could be a nurse, it could be a case manager, or you can split it. You can have a case manager and MA. And basically, they're in charge of keeping up kind of an Excel sheet. So a patient comes in a primary care setting, they get a PHQ-9, it's high. The medical provider sits down with them, discusses the options for care. The provider will say, I would like you to meet my friend. It could be a behavioral health consultant, a case manager that is going to help us with the treatment for managing depression. What you're doing is you're doing a warm handoff to a team member, so those individuals who will then put them on an Excel sheet so that we can do phone call follow-ups. We can ensure that we're doing PHQ-9s, that we're getting to that 20% improvement of the PHQ-9, for example, when you start a medication. So it's structured, it's doable, and the website that I recommend a lot of people to find protocol is called AIMS. It's from Washington University.
Well,
Okay, so these are the core principles that make collaborative care actually work. So I just want to review it because it's not something that's out of this world. Like these are things that we have been talking about in medicine. So the first one is patient-centered care. This sounds pretty obvious, but in siloed systems, care is often provider-centered. So collaborative care recenters the whole thing around the team for the patient. Population-based care, this is where things really change. Instead of waiting for patients to come back, we actively track them, like I was saying, so no one falls in the cracks. The third one is treat to target. So we're not just prescribing and hoping that they'll improve. We're using objective scales like the PHQ-9. That's just an example. There's a lot of collaborative care protocols that are focused on substance use or maybe anxiety. But for this example, I say PHQ-9. And then we adjust treatment according to how the improvement is happening or not. The fourth or the last one is evidence-based accountability care. So we're not just delivering care, we're really focusing on outcomes. And I think that's when we put things together. We always see in these medical literature or guidelines is like we treat for outcomes. How do you do it? So this is why collaborative care allows us to shift from a reactive type of care to proactive. That's the big difference.
it almost sounds like optimal team practice.
It is. It is, but exactly. We talk about all of this, but how many people have really jumped in and did it? And
Emotion.
And I have been involved in creating a collaborative care program in a previous position I was in. Co-leaders and a team that really wanted to change the system instead of the status quo. They went to a conference called the Train the Trainer Fellowship Primary Care Psychiatry. And that leader brought me in because I was interested. When providers start talking and saying, like, let's make change, that's where things can happen. Collaborative care model is twice as effective in the study with older adults. Over 80 random controlled trials, specifically on collaborative care compared to the usual care. It doesn't just improve the outcomes, which is really great. It actually improves how we feel as providers providing care, reduce burnout, and it helps the patient feel heard and taken care of instead of just being passed around.
Imagine a patient with like satisfaction.
Not just for a Yelp review, but for actually
Mhm.
like, I went to the clinic for X reason, and I am now addressing several things that I've been putting aside or not putting a light on because I just needed more support. It's something that we all should be trying to implement in our practices is collaborative care. So what does it actually look like in practice, right? Even if you don't have a formal program, I really want to emphasize you can start with just the principles. Be the shaker at your practice, meaning like
Mm.
take the research, show it to the leaders, or become a leader, because that's what I did, and make this change. And so you don't have to have a formal program. You can start with the principles. It can be a simple thing using the PHQ-9 consistently, using it as a trigger for a warm handoff instead of a referral. Start doing collaborations. Like if you do have a mental health provider, find a way to start communicating with them in a more consistent, strategic way or hire. You know, there's a lot of grants out there that PAs can
Mhm.
sign up for and get and try to do this program as a pilot. That's how I started some other system-wide programs is we start as a pilot, look at the data, review it with leadership, and we make that type of change in how we provide care in the practices. So overcoming implementation. I have to be honest, there's a lot of barriers. I'm not trying to paint this as like, it's so easy, but it's worthwhile. So There is time. So you need some leaders to step up. You need a workflow, which I already gave you some great resources with Ames, University of Washington. And then there's reimbursement. So University of Washington website will go over some of the ways you can kind of like benefit from doing the collaboration within your practice. So there's some coding modules and references that you can go into. And the communication gaps, you looking at what's working, what's not on the ground floor is going to really help break down that system barrier. So you're aware that it's not a provider problem, it's a system problem, but we can make efforts to make it better. So, key clinical takeaways here is at the end of the day, collaborative care is how we move from the silos to systems, and PAs are uniquely positioned to lead that shift, to be leaders, because we already live in this intersection of specialties, right? So, I know so many PAs that work in cardiology or oncology. And so we have that wider
Like
lens.
flexibility,
Mhm.
malleability.
And then also, we have been trained for collaborative communication, right? We consult with interdisciplinary team, MDs, NPs. I mean, like, don't you work with a pharmacist too? Like, I worked with a pharmacist. So we kind of already know the language. And so we can be part of building this. So that's it. And Jessica, I just flew through that because I'm just so passionate about it. But do you have any questions? Or what do you think?
So can we go back to the slide before?
Yeah, of course. This one?
So just wondering, it says like caseload consultation leverages one psychiatrist across
Yes.
our primary
I
care providers. Does it have to be a psychiatrist or can it be psychiatric providers?
It can be a psychiatric provider. So thank you so much for
Mhm.
calling me out. I was a psychiatric PA in the collaborative care model in
I
my
was
previous
wondering. Mhm.
practice. So that is a typo. So it has to be a trained psychiatric provider. So it could be a psych PA, psychiatrist that is kind of the person in this clinical coordinated connected team. So I mentioned the Excel sheet that has to be done by a care manager, and that care manager and that Excel sheet does checks on how we're progressing or not progressing. And what happens is once they review those that are not progressing or lost a follow up, that's why the care manager will do some phone call follow ups or get the patient in sooner. If there are poor outcomes, you do a psychiatric consultation. So we had monthly consultation meetings. So I sat down with the internal medicine providers or the primary care providers, and we reviewed the patients that were not progressing. We were
Mhm.
reviewing what is missing in their treatment. And then the primary care providers would also just consult with me. It's like, I need to review this case. So maybe there was a differential diagnosis that we need to think about, or something that was comorbid, or something that we need to consider changes in medication, such as adding a second generation antipsychotic, atypical onto an SSRI, or changing to SNRI for some other reason. So it was really kind of tailoring for the patient's treatment, as well as increasing the primary care provider's confidence in psychiatric management. And so that's what's the beauty about this is that it's kind of like training the system to provide higher level care in psychiatry. And it says psychiatric consultant, but it can be like a psych PA or a psych NP.
Mhm.
Mhm.
Yeah. And then like on that other side, there's shortages with psychiatric providers. And here we are,
Yeah.
there's so many well qualified psychiatric PAs who would love to be in this position and still dealing with state and legislative barriers to
Yeah. And
preventive
that's
care. Mhm.
exactly. And so I think that I don't know if the viewers or the followers know, but that Jessica and I step up in legislative work in our specific states and organizations. If you have not already, please become a member of your state PA organization or your state medical organization and the national organizations. All of that money for political action, donations, your time is important to change the archaic legislative laws about PAs, because PAs are able to provide excellent care. So it does take a village and a community to make that change. This doesn't happen on the sidelines. You have to jump in.
Absolutely. And it's just that we're such a newer profession. Sometimes we're just really not thought of. It's not that we're not capable of doing these things. It's just legislation forgot to
Mhm.
include us. I love the idea of doing this as a pilot. Can I get a grant somewhere? Like, where do you think is a good place to look for funding for people who want to start something like this up?
NCCPA and PA Foundation have some
That's what I
excellent
was thinking.
grants, and you
Right.
can just look it up online. They are for PAs and PA students. If you have a vision, look at the research and look for opportunities to make change.
Well, this has been really helpful. I have a whole different understanding. I always think of collaborative care as like, oh, you make a phone call and you talk to the person. So this is a whole different model, which is really cool to know about.
Well, thanks for joining us. Hope that this was knowledgeable for you guys too. All right, you guys take care.
Bye.
Thanks for being here with us at Mini Mindset Series. Our hope with this is simple, that one small insight today sparks a different question, a different conversation, maybe even a different outcome for one patient. Because small mindset shifts ripple into clinic, into leadership, into life. Until next time, take care of your patients and take care of the clinician inside of you too.